Hi, it's Nikki Lowe and welcome to the Wisdom for Working Mums podcast show. I'm your host, and for nearly 2 decades now, I've been an executive coach and leadership development consultant. And on this show, I share evidence-based insights from my coaching, leadership and psychological expertise, and inspiring interviews that help women like you to combine your work, life and motherhood in a more successful and sustainable way. Join me and my special guests as we delve into leadership and lifestyle topics for women, empowering you to thrive one conversation at a time. I'm so happy that you're here, and let's get on with today's episode. Over the last few years, perimenopause has been a real roller coaster for me. It's also been a steep learning curve into hormones, female health, and just how little many of us really understand about what's happening inside our bodies. As someone with a strong family history of breast cancer, I felt deeply conflicted about HRT. I was trying to weigh up my quality of life against concerns about risk, and at times it just felt overwhelming. Last year, things reached a point where I felt like I was trying to balance my sanity with my safety. I knew I needed support to understand my options rather than stay stuck in fear and uncertainty. And that's when I found today's guest, Dr. Charlotte Gooding. Charlotte is a GP, a BMS-accredited menopause specialist, and someone with deep expertise in supporting women with complex breast cancer histories and concerns. She works in an NHS breast clinic and has built a specialist service supporting women navigating menopause after breast cancer, as well as those at higher risk because of family history. Over the last year, Charlotte has guided me so compassionately through my own HRT journey, helping me understand whether HRT could be an option for me and how to approach it safely in the context of my own risk factors. It was also through that process that she helped identify that I had a large fibroid, which ultimately led to me having a total radical hysterectomy about 8 weeks ago. I feel deeply grateful for Charlotte's support, and I also know how privileged I am to have had access to that level of specialist care. And that's one of the reasons I wanted to have this conversation, to make her insights, expertise and reassurance more accessible to other women who may be feeling confused, frightened or alone in navigating all of this. Now, I do want to say before we begin that this episode reflects my personal experience, and this conversation is not a suitable substitute for individual medical advice. Every woman's situation, history and risk factors are different, so it's really important to do your own research and speak to a qualified health professional about what's right for you. But in this episode, we're exploring perimenopause, HRT and breast cancer risk, and having the kind of honest, nuanced conversation that I know so many women are desperate for. And my hope is that this episode helps you feel more informed, more empowered and less alone. So I won't keep you any longer. Let's welcome Charlotte. Welcome, Dr. Charlotte. Thank you so much for joining me on the podcast. I can't wait to dive into this conversation because, of course, we've been working together for nearly a year now. So I've got to know you and all your expertise, and I'm just really delighted that you've agreed to come and share that on the podcast with my listeners.
It's an absolute pleasure to be here. It's lovely. Thank you for inviting me.
So obviously we're going to be talking about today perimenopause and the menopause. And I am sure people have heard lots of that because you can't go anywhere these days without hearing those terms in some way, shape or form. But for many of us, we may not actually have heard the definitions of these and truly understand it. So for those that don't, can you just describe what we mean when we're talking about perimenopause and menopause?
Yeah, sure. So menopause is just really one day in a woman's life, which sounds a bit disappointing when you think of all the hype around it. It's when you've had no periods for 12 months or more. Now, obviously, that definition slightly shifts, and obviously someone who's had a surgical menopause, that's going to be slightly different because they're going to go into a sudden menopause. And there's some other situations where people might go into what we call a chemical menopause. So people who perhaps are having certain breast cancer treatments, or who might be using things that turn off their ovary for, say, treatment of endometriosis or premenstrual dysphoria. So there are other ways which women can go into menopause, either suddenly or perhaps surgically. But generally, when we talk about menopause, we're talking about a woman who has not had periods for 12 months or more. And that is the sole definition of menopause. Anything after that is postmenopausal. So you're kind of postmenopausal for the rest of your life. And then more now, we're hearing about this kind of perimenopause phase. And that's the time leading up to the menopause. And it can be anything from about 10 years before natural menopause takes place. So menopause usually happens in women. Average age in the UK is about 51. So if you think 10 years before that, it's quite feasible that women in their sort of early 30s, even late 30s, early 40s might be experiencing some perimenopausal symptoms. Anything from the age of 45 onwards is considered a normal menopause. So if you have it from 45 onwards, it's normal. And anything before that is an early menopause. Perimenopause is it's a bit of a buzz at the moment. People are talking about it more. When I sort of first started at med school, no one had ever heard of perimenopause. I don't think anyone was really talking about women's health, to be honest. But it's brilliant that we're kind of starting to look at that transition phase. And that's basically what I would liken it to, really. It's before the ovaries kind of pack their bags and give up altogether. They have I call it to patients a bit of a final hurrah, where they just go a little bit erratic and all over the place. And actually, that's pretty much how women feel in that time as well. So they feel quite erratic and up and down, and symptoms can be very variable. In that early perimenopausal phase, women might experience some changes to the menstrual cycle. The periods don't have to have stopped or to have lengthened in their cycle time, but they might just feel like they're a bit heavier. They might be coming more frequently. They might be getting some bleeding in between periods. And so it's characterized by those changes, but they don't always happen in early menopause. And sometimes we see more of the kind of psychological symptoms coming through, rather than menopause, we associate it with the hot sweats, the night sweats. Actually, in that early perimenopausal time, women are more coming to us with kind of, the mood type symptoms, I would say, than those kind of hot flushes, night sweats.
And I think that's really important for people to hear, because I know in my own perimenopausal journey, I didn't realise that. I was expecting to have, as you say, the hot flushes or the hot sweats. That was or people talked about perhaps aching bones or kind of aching kind of almost limbs. I was looking out for that. So when I was experiencing this emotional turbulence, it crept up on me so gradually that I didn't really notice until I was like, I don't feel myself anymore.
And that's quite common. So I often say to people, it's a bit like, when you go for a walk and it's quite misty and a little bit misty and foggy and the visibility is not great. So that's like a few of those symptoms coming in. And then you're carrying on your walk, and then all of a sudden you're just going along your walk, along the path, and you look up and you're like, oh my goodness, I can't see anything around me. I feel completely lost and disorientated. I think that's a bit like what perimenopause is like, because the symptoms are kind of gradual and they're sometimes subtle. And then if you're not open and recognizing them and kind of alert to what's going on around you, then you can find yourself kind of in this deep fog that it feels a bit harder to find a pathway out of. So I kind of like that analogy. I like analogies for things, and I think that's quite a good one. But you're right, it is sometimes really hard to notice the symptoms of perimenopause because perimenopause hits women at a stage in life when there's lots going on. We might have, some of us have got children, and some of us have still got young children, and some of us have got children who've just left home, and that's a new life transition phase. We might be dealing with elderly relatives who are aging, who are perhaps sick, and you need to be there for them and caring for them. Work situations, often actually women are sort of at quite a pinnacle phase of their career. They've had some time off, perhaps for maternity, they've returned to work and they're really getting stuck back in. Work is busy, it's stressful, it's that mental load that we're all carrying as women, holding up the sky. And And so those tiny little symptoms sometimes get confused with other things that are going on in life. Like, am I not sleeping because I'm really stressed at work? Is this just stress? Am I just feeling completely overwhelmed and burnt out? And it's sometimes really hard to kind of tweak out all the individual symptoms and say, well, this is life, this is perimenopause, this is your hormones. It's difficult to do that because lives are complex and everything affects everything else. And so it's not always about that. It's about looking at the whole picture.
Yeah. And I think that's what you do so brilliantly. And so many women that I've heard of in my kind of network have gone to their GP with symptoms that do feel psychological or emotional. And the first port of call is, let's put you on antidepressants. I feel like antidepressants will help here. And anecdotally, I'm hearing, but it's not helping. So what might be, if you were to kind of paint the picture of potential range, and I know it's so individual, what could somebody be coming to you with and you go, this could be perimenopause or part of the perimenopause picture?
Yeah, so it's hard because there was probably like 35 plus symptoms of the perimenopause and counting, I would say, because I see things all the time. So you have estrogen receptors from the top of your head to the tips of your toes. So every part of your body can be affected. So you've got like the mood type symptoms, you've got fatigue, sleep patterns can be disrupted because they're quite hormonally controlled. You've got things like vaginal, vulval symptoms, urinary symptoms. They're the ones that probably women don't pick up on as much. And I know you've spoken before about how you didn't really piece those together for yourself. But, low libido. But then again, libido can be really affected by everything else that's going on in your lives. Dry eyes, dry mouth, dry skin, hair drying, hair falling out. I could go on. Even things like tinnitus, that's a really common symptom, restless legs. The problem is that sometimes you've got to be careful because sometimes these symptoms are also symptoms of other things. So quite often when women first come and there's this kind of picture of these evolving symptoms, it is sometimes a really good idea just to make sure that nothing else is going on as well. Like what we don't want to do is we don't want to be caught between the two extremes where we're saying, nothing is perimenopause. And then we're saying everything is perimenopause, menopause. And so we miss stuff. So actually sort of looking at the bigger picture. And of course, that is quite tricky because it is hard to do in a 10-minute GP consult. My background is in general practice. I've worked in general practice for years. And it's sometimes hard to do that. And I think that, but if you ask women and you really listen to them, they will tell you, I'm not depressed. And I think women do know their own minds and they know their own bodies. And it isn't the same as like a true depression. And often what I'm looking for is those kind of fluctuations in symptoms. Are they at all related to the cycle? Have there been some cyclical changes as well? So are periods changing? And just trying to kind of piece those symptoms together with what's happening for that person. Now, that's not to say that other things might be influencing them. Of course, if you're really stressed out, your stress load is going to be higher. And so you are going to feel some of these symptoms more. But in a way, that's the kind of beauty of what we do. Nothing exists in isolation. So it's about picking out those symptoms, working out how they're impacting on that person and what we can do to support them.
Yeah. And what I loved when I first came to see you, so for context, I'd probably been struggling with perimenopausal symptoms, some that I was aware of, some that I wasn't aware of for quite a few years. But as we'll get into, I've got a very strong family history of breast cancer. Both my mum and my grandmother died of breast cancer. And my mum and dad both were one of 6 children. And every single one of my mum's siblings has had cancer in some way, shape or form. And on my dad's side, there is kind of 4 and grandparents. So I'd got kind of both a strong maternal and paternal history of cancer in my family. So I think I was very scared of looking at potential HRT options. And I know we're going to get onto that. So I tried to do everything as naturally as possible. So I'd looked at my diet, I'd looked at my exercise, I'd looked at supplements, and I'd for years had been kind of layering on, going kind of, let me try and do this as, I suppose, naturally as possible. But I noticed that I became quite anxious, and I'd never been an anxious person before. And I hear that a lot. So my resilience, I just didn't feel resilient to everyday life. And I'm like, I've always prided myself on my resilience. So I was like, that's interesting. I became incredibly irritable, and that's just not part of my personality. So I'd got no patience, and I could go to rage quite quickly. And I'm like, who is this person? And again, I'm sure you hear it a lot. I hear that a lot from my friends. And my cycle had changed. So I was having a longer cycle. I was bleeding more and getting more and more heavy. And just like you said, that was something that I was like, oh, that's just perimenopause. And I remember saying to people, oh God, this is the gift that keeps giving. Because I thought menopause, your period slowed down and got less. And I was like, oh no, mine are just getting more. And I'd got to the point where I had lost my connection to joy. And I remember somebody saying to me, I've just become a shell of my former self. And I was like, that is it. So I decided to reach out and have that conversation with you.
And that is probably a familiar story that I will hear all the time in clinic, or just amongst women that I'm talking to, you know, that real lack of self, that kind of not recognizing this person who they are. And I think the anxiety can be quite frightening if you're not someone who is being an anxious person, and all of a sudden you're getting quite a lot of anxious feelings, and quite often sort of quite overwhelmed by those feelings, and not really able to kind of justify them and sort of say, well, yeah, that was a really anxiety provoking situation, just overthinking, over worrying. And that can be really scary if that happens to you out of the blue all of a sudden, and it's sort of taking over your life. You know, it's affecting your sleep, because you're kind of waking up in the night going, oh my goodness, what if this happens? What if that happens? What if I can't get back to sleep? And it just becomes all consuming. So yeah, anxiety can be a really big one. And like you said, that irritability and that rage. And I think just that threshold, you know, we all have this window of tolerance to be able to cope with things. And I think that window of tolerance really narrows when you've got all this other stuff going on. And that is something that I hear women say a lot. And it's hard, because it's often embarrassing if you've suddenly flown off the handle, or, you know, you've flown into this rage, and, you know, you spend a lot of time trying to make up for that and saying, oh, I'm really sorry, I completely overreacted. No, I don't really know why that happened. I can't even explain it. It just comes over me like that red mist. And it is very true. And I hear that a lot from patients. And I think that can then make things like relationships work really quite difficult.
Yeah. And the other thing that I started to experience, and not so much as some of my friends, was that brain fog. Like literally I would kind of feel like I was wading through mud. Mm-hmm. Like I'm normally quite a switched on, productive person. I'm like, God, I just feel like I'm wading through mud. And there would be times, there were particular words that disappeared from my memory. Yeah. One of them was skirting board. And I would be talking to people, go, you know, that bit that sits at the bottom of a wall, and it's that bit of wood. And literally skirting board disappeared from my memory. It was like it just got erased. And I was like, oh, isn't that weird?
I mean, and women can often say, you know, I think I'm getting dementia here. I feel like, oh my goodness, I've seen this happen to my grandma or my mum, and I feel like I'm getting dementia. And that is frightening, especially, you know, it can really impact on things like your confidence to do your job. You know, if you're getting up doing presentations, or you're just trying to have these high level conversations with people, and you've just forgotten the word that you've used every day for God knows how long, it can really affect your confidence in your ability to do your job. And I think that's really important. And unfortunately, you know, I have seen a huge number of women exit the workplace, or, you know, not take a promotion, or step down a level, because they've been so affected by those things, and it's really rattled their confidence, and often they haven't had much support in the workplace either. So I think those things are really significant and really important.
And I think that's really powerful that you've said that, because I used to go to a yoga class where the women were predominantly in their 50s, 60s and perhaps 70s. And I remember them having a conversation about the menopause and perimenopause. And 3 of them had said to me in different guises, oh, I left my job because I could no longer do it, or I left my marriage, and then they were like, and then I went on HRT and went, oh, I didn't need to leave my job, or I need to leave my marriage, And I was like, okay. And I remember clocking that. But again, because of my family history of cancer, I was like, oh, I don't know if HRT is an option for me. And so just to layer in, I ended up reaching out to you probably about a year ago. And I specifically was looking for somebody that was a menopause expert with a kind of specific knowledge of breast cancer. And I was so glad I found you. And I think you did this brilliant intake session with me where you looked systemically at everything from my family history to my symptoms to my lifestyle. And one of the things that you've already mentioned about kind of vulva health, it's about 18 months ago now, I ended up having this sensation that I was like, what the hell is that? Never had anything like it before. And I was just this burning sensation. And it was so horrific. Like I'd never experienced anything like it. I ended up having to go to my GP to get a swab. And I was like, what have I got? Have I got some kind of STD? Or I'm like, how the hell have I got something like that? And it turned out to be thrush. And again, in conversation with you, you were like, oh, UTIs, thrush, they're a really kind of common side effect that you don't hear anybody talk about. Like I'd never even made that connection.
No, and there's probably hundreds of women, I would predict, that are entering into various pharmacies all over the country right now, getting another thrush treatment and just sort of self-treating for these things. Or, you know, when I was in general practice, I always used to be really sort of switched on to the women who were repeatedly asking for the thrush treatments and then kind of looking at their age group and thinking, shall I have a chat with them about perimenopause and what this might actually be? Is this actually thrush? And I think, you know, women still find it incredibly embarrassing and stigmatizing to talk to health professionals about, you know, genital symptoms, whether it be itching, burning, whether it be painful sex, whether it be urinary incontinence type symptoms. They find it really hard. So they do look for things that they can just kind of get hold of themselves and sort of self-treat, which I just think is incredibly sad because, you know, I think as well, we're probably not that good as health professionals sometimes about opening up those conversations, and that needs to get better as well.
Because I love the actress Halle Berry talks about this a lot. So she talks about how she discovered that she was perimenopausal, or she had what the doctors told her was an STD. And she went and ended up, I think, falling out with her boyfriend at the time, going, you know, have you given this to me? And it wasn't actually. But again, there's not that many people talking about it. So what came out of our discussion was that the heavy bleeding. And I remember you saying to me, I'd had a fibroid when I was pregnant with my second child that had led to a planned C-section. And you'd said, can you go and get that checked for me? Because actually we need to look at that first. Can you give a little bit more context around that?
Yeah, so I'm always, I guess it's very easy to kind of just go, oh, perimenopause, you know, changes in bleeding. But I'm always suspicious. Like, I think probably bordering on nosy, most people would say, is like, I love a little nose into people's histories. And I really like, when I'm speaking to patients, I really want to know all about them.
Curiosity, it's professional curiosity.
It's probably why general practice I find so hard, because I'm like, 10 minutes? How can I possibly hear everything about this patient? I really need to know the nitty gritty. And so as we've been talking, I was thinking, you know, about that. And then you'd said that your periods were getting heavier. And I just thought, I need to know a bit more about that. And that's when we kind of said, look, I think we should just check that this fibroid, you know, hasn't, under the influence of more hormones in your life, hasn't grown back. Because what I was thinking was, if we're potentially going to think about something like HRT, I'm going to give you some estrogen, and estrogen grows fibroids. So you won't thank me very much if I then cause your bleeding to get heavier. So there's often little cues in patients' histories that will make me curious, and there are sometimes things that we would just like to check out before we get started. And a good job we did, really.
Yeah. So for people listening, when I went and had a scan, it turned out I'd got a 9 by 8 centimetre, quite large fibroid that ultimately led to me having a hysterectomy about 8 weeks ago. So I am now classed as a kind of medical menopause. And thanks to your support, it has been such a positive journey for me. So in that, you've already talked about estrogen. Can you talk a little bit about the hormones that we might be connected to perimenopause and menopause? Because again, I think there's a lot of confusion around
I think
them.
there is. I think, you essentially, your ovaries make estrogen, progesterone, and they also make some testosterone as well, which I think sometimes shocks women because we think of testosterone as this male hormone, although there is a lot of chat, I think, about testosterone in women now. So, they're the three main hormones that we're looking at. And obviously, when someone goes into menopause, if they've had their ovaries removed because, surgery or whatever, then we need to replace those things for them in order for their symptoms not to suddenly get very severe. In perimenopause, we're kind of just holding up the system. I call it a bit like a flight deck. So in perimenopause, your hormones are going up and down and all over the place. And at times you'll get very big dips in estrogen, and that can make you feel quite symptomatic. But actually at times during perimenopause, you can have quite a lot of estrogen circulating, probably perhaps more so than other times, apart from obviously when people are pregnant. So the way I describe it in perimenopause is almost like you're building in a flight deck. So you're trying to stop the lows, but you equally don't want to give so much that if their own estrogen goes a bit high, it's too much and their body just feels a bit overwhelmed. So it's quite tricky, actually, sometimes getting that balance right. But obviously, when someone is put into menopause or goes into natural menopause, then we're replacing the hormones. That's not to say that there's no hormones left at all in your body when your ovaries go goodbye or get removed. You will still produce some weak forms of estrogen in fat cells. That's why we get that lovely tummy during perimenopause, menopause. The body is trying hard to lay down some fat cells to get some kind of estrogen going around the system.
And I never knew that was why.
Yeah. And then your adrenal glands which are by your kidneys, will produce a little bit of testosterone as well. So we're not devoid of hormones post-menopause, but just not at any level that is the same as when we're premenopausal.
So if somebody was to come to you as a menopause specialist, you'd be looking at actually what are the signs and symptoms that might tell you what is going on between those hormones and the mix of it.
Yeah, absolutely. And obviously progesterone also starts to decline. And that is sometimes the reason why we can see this heavier bleeding. And irregular bleeding as well. So it's about those. They're the three main characters that we're kind of looking at. But you've also got to remember that things like your hormone, those hormones are also really connected to other hormones in your body. So things like thyroid. So if you've got a thyroid issue, you can often see that might change, or your requirements for your thyroxine medication might change as you go through perimenopause. Parts of the body don't exist in isolation. In medicine, we love to put things in boxes. We like to say, right, we're dealing with that, we're dealing with that, and we're dealing with that. But that's just not how these systems work, really. It's like a harmony. Everything has to go on together, yeah.
And so you've picked an area of kind of medicine. I suppose you are a general practitioner, but looking at kind of the menopause specialist, it is so tricky, isn't it? Like, I know I came to you going, well, I know that I've got an estrogen dominance. And I suppose one of the reasons I probably had a fibroid was I'd got kind of estrogen that was feeding it. But I'd also got polycystic ovaries, which can have, you've got increased androgen, so the male hormones, so potentially higher testosterone. So I remember we had a conversation about that and me going, my assumption would be I wouldn't necessarily benefit from a testosterone, but you actually said that hasn't been anecdotally what you've experienced.
Yeah, I think I think every woman is different. And I think particularly when it comes to testosterone, I really think that everybody's different. But I also think that we all have different sensitivities to the hormones that are in our body. Our bodies react differently to them, and particularly in the brain, I think our receptors are very different depending on different people. And you certainly see that across the board when you're working with different women. So, polycystic ovarian syndrome, that we typically think about that as being, people worry about it when it comes to fertility. So everyone's like, oh, it might cause a problem with having children. It doesn't always, but really and so then they have babies if they want to, and we sort out their periods so that they're having more regular periods, because obviously one of the hallmarks is that you don't have regular bleeds, and that can be dangerous for the womb lining. So we need to make sure you do have regular bleeds. So we sort all that out in sort of early life, like in our early reproductive years. And then we kind of forget about it. But actually, and I'm sure we've talked about this, is that PCOS is a lifelong metabolic condition. And if you have PCOS, then you are at higher risk of metabolic disease throughout life. You're higher risk of cardiovascular disease, higher risk of type 2 diabetes, higher risk of things like endometrial cancer as well. So we need to be thinking about women's, not just their lifespans, but their health spans, and looking at how these conditions are going to affect them going through the rest of their lives. Because you've got like 3 decades left and you want to live them well and healthy, and we want to try and reduce the risk of disease. So for certain women, their hormones play a much more sort of main role in their life and in disease processes. And we have to be able to identify those women and be able to kind of look after them, I suppose, as time goes on. And you're right, raised testosterone is a hallmark of PCOS. But it's quite interesting in that women tend to see is that women with PCOS tend to come in perimenopause with more regular periods. So all of a sudden they'll be like, oh, I just never really got periods. I might have been put on something that made me have a regular bleed. But now in perimenopause, the first time in my life, I'm having a monthly bleed. So you see that quite frequently. The testosterone thing, I think, is interesting and complicated. It's really hard to identify women who will need testosterone or who will respond well to it. And so it's about kind of looking at what their levels are. I don't think, and I haven't seen in clinical practice, that really levels correlate to the way patients feel or their symptoms. And one of the problems is that regarding testosterone is that we have very little data apart from things like libido. And so whilst anecdotally, we will see that some women really benefit from testosterone in terms of mood, sometimes cognition, that kind of joy feeling, which is really hard to pin down in a research study. We don't have evidence to support its use for that. So it makes it a little bit more nuanced. And that's why we have to kind of take each person as an individual when we're looking at those things. So some women, yes, will really benefit from testosterone. Some women, it won't be appropriate for. Their levels might be sitting a bit higher anyway. And if you give it to them, you'll probably load them with a load of side effects that they won't thank you for. And some women, you give it to them and just they don't feel any different. So I suspect, and this isn't scientific, and I don't have a study to back this up, I suspect that everyone just has a very different response to testosterone. So I think some women perhaps are quite driven by it, and perhaps, that point in their cycle, usually where the testosterone is higher, that's their time, just for ovulation, they're driven, that's when they're the most productive. Other women, it just doesn't really factor in their cycle. It's not something that they're driven by. But that is just by looking, there's no evidence behind that. That is just my observation of women over time, treating hundreds of women.
And that would make sense because I also hear friends anecdotally talk about their experience of progesterone. But before we move on to that, something that you educated me on, which again, people may not know, because some women are like, just give me the testosterone, it'll give me the boost and give me my oomph back. And you made it very clear, actually, if we don't get your estrogen levels right, is it right that testosterone just converts to estrogen?
Yeah. So the testosterone will convert to estrogen in the body. So if you haven't got enough estrogen, then testosterone is probably not going to work that well for you anyway. And I think so I tend to do things stepwise. And I always think as well, it is always better where you can. And I'm sure we've had this conversation about just doing one thing at a time. Whether it's hormones, whether it's other medication, years of clinical practice have taught me when you try to do too much all at once, it's generally a disaster. So I try to just introduce as much as possible one hormonal change at a time, because that allows the body to adjust to one thing and it allows us to see what's benefiting, but also what might be causing some side effects as well.
You've really got one variable to kind of measure.
I just like to keep things simple.
Yeah. Obviously, I'm slightly different because I have had a total hysterectomy. But for the typical woman who still has her reproductive kind of organs, when it comes to HRT, can you just take estrogen, or is it right in saying you would need to take a combination?
Yeah. So essentially, if you've still got your womb, you need to take progesterone alongside estrogen. And the reason for that is because estrogen makes womb linings grow. So if we just gave estrogen to women who had a womb, their womb lining would grow and grow and grow. And if we don't stop uncontrolled growth, that's when little mistakes can happen in cells. And that's when we might get the risks of endometrial cancer or womb cancer. So it's really important that if women have got a womb and they're taking estrogen, they have some kind of progesterone alongside it. Now, if you're still having periods, even if they're not particularly regular, and say you haven't been 12 months without a period, so you might have had 6 months of no bleed, we would generally put you in a cyclical regime with the progesterone. So tend to do 2 weeks on, 2 weeks off, or for 14 days, 12 is the minimum. It varies a little bit, so you probably hear differences amongst women, but generally 2 weeks on, 2 weeks off of the progesterone. And when we take the progesterone away, you get a period-like withdrawal bleed. So you get a regular bleed as part of that. If you are 12 months post your last period, then you go on continuous progesterone. So you take your progesterone every single day. And there are different ways of doing that. There are different types of progesterones and progestogens, which are more synthetic. And some women might have something like a Mirena coil, which can do the job of protecting the womb lining. It just sits, it's progesterone in the coil, it sits inside the womb and does that job. It's like a little lawnmower, keeps the womb lining nice and short, so we don't have to worry about it. But if you've not got your womb, generally you can have estrogen only HRT. However, there is a caveat to that, in that if you are someone who has had endometriosis diagnosed, particularly if it's just mild endometriosis, we sometimes don't add progesterone. But generally, if you've had endometriosis, quite extensive disease, then you would put some progesterone back, because the hallmark of endometriosis is that you've got endometrial, so womb lining type cells that are outside of the womb. So even if we remove your womb, you're still going to have those little cells, usually in the pelvic and abdominal cavity, but they can be in other places as well. So we have to make sure that they're not reacting to the estrogen.
Yeah. So one of the conversations we had as part of my plan, wasn't it, that I was having my cervix removed as well. And you were like, actually, if your cervix is removed, I know that I can actually just get.
And that's the other time. So sometimes people have what is called a subtotal hysterectomy, which means that the cervix remains. It's quite rare now. It used to be done more in the past. I very rarely see that now, but we always check with women, because some endometrium, so some womb lining cells, can be in the stump of the cervix. So you just need to make sure. So what we would tend to do with those is that if we're not sure, or if we think they still have their cervix, is do a bit of a test and see if they bleed. And if they do, then we'll have to keep them on some kind of progesterone. But if they don't, then they can have estrogen only HRT. So it's individual, and it gets quite complex when you really get down to the nitty gritty.
And also because people might hear about, from an estrogen perspective, some people are on patches, some people are on gel. And can you tell us a little bit? I mean, again, I know it's so nuanced, but just at a high level, what the differences are and how you would kind of explore those.
I mean, we've got very fortunate over time in that we've got better ways of doing things. So previously, we were mainly using oral HRT. So whether that be oral estrogen alone or a combined oral and progestogen product. So that was kind of the way that HRT was done, and it was using kind of conjugated equine urine, horse's urine, and it was not a great form of estrogen, quite high risk for blood clots. And so we don't tend to use that anymore. We now have more body identical types of estrogen, so estradiol. Body identical means that when you look down the microscope, it looks the same. It isn't the same. We haven't extracted it out of someone else and we're putting it in you, but it looks the same in chemical structure as your own body's natural hormones. And so the body tends to work a bit better with those. And we can get body identical forms of progesterone as well, but we can use synthetic progestogens. And the type of HRT really matters, because oral HRT gets metabolized in the liver. So that means that it can affect clotting. So there is a risk of blood clots, so in the legs or the lungs, so DVTs, pulmonary embolisms. There's a risk of those when you take oral estrogen, whether that be alone or whether it be with progesterone as well. So now we've got transdermal products, so products that go through the skin for estrogen, which is great because that means that people who perhaps would have been told you can't have HRT because you've got a high risk of blood clot, you're a smoker or you're overweight, or you perhaps have got some genetic issue that predisposes you to blood clot. Now those people can have HRT because they can have estrogen through the skin in form of patches, gels, or sprays. And the other thing to say is that quite often what would happen is that people would start on HRT, but then as we age, so you'd start on oral HRT, but as we age, our risk of blood clot goes up. So then people would be told, right, well, you can't use that anymore because it's too risky in terms of blood clots. They would have to come off it. But now, because people tend to be using the through the skin products, so the patches, gels, or sprays, they tend to be able to stay on HRT a little bit longer, and people that perhaps couldn't have HRT in the past can now take HRT. So there's been some sort of big changes over time, and sometimes we're not always caught up with those changes in the medical field, I think. It's a lot. It is a lot, and it's a lot to get your head around. And I think that's why everyone has to have these individual discussions, because there isn't this sort of one size fits all, and what your friend might be doing might not be suitable for you. And I guess sometimes that does worry me a bit, because I do see, a lot of forums and a lot of chat on the internet, and women sort of saying, oh, well, you could try my HRT or whatever. And I'm thinking, oh God. So I think it's really important that the type of HRT that you're taking is individualized. For example, that in terms of progesterones and progestogens, so the progesterone is the body identical, what the body naturally produces, and the progestogens are the synthetic forms. There's even a difference between those. And I might pick different ones depending on what's going on. So if I've got someone who's a bit of a bleeder, has always had heavy bleeds, I might choose a synthetic progestogen. But generally, progesterones are better tolerated. So you probably heard of like the Utrogestan and things. They're better tolerated. So if someone's a bit sensitive to synthetic progestogen, I might choose that. So it's all about choice. And the more options we have, the more choice women can have and make, and the more widely available then HRT becomes to different groups of women, which is brilliant.
And I love the nuance that you bring to this. So what I'd love to move us on to now is the specifics around HRT and breast cancer specifically, because I think there has been a lot over the years of concerns, then people kind of bringing out new research. And I know you're at the forefront of kind of the latest on this. Would you mind just sharing what some of those previous considerations were and what we now know in March 2026?
Yeah, so I think the whole world of HRT was pretty dominated by the Women's Health Initiative study, which came out in 2002, and it was very vilifying of HRT, and particularly in terms of cardiovascular risk and in terms of breast cancer risk. Looking back now at that, it should never really have been reported in the way that it was. And a lot of the data was not reported in a very responsible way, shall we say. And so it sort of over-egged, I would say, is the risk of breast cancer. And so immediately overnight, women were taken off it. And that was when I was sort of in training. So I'm interested in HRT probably because my mum had a very early menopause, and she had a surgical menopause when she was in her late 30s, or might be mid 30s actually. So she was really young. So obviously had been on HRT her entire life, and I just thought it was really normal. And then I'm getting onto the hospital wards, and I'm thinking, oh, why doesn't this woman have HRT? She's having a hysterectomy. And the gynae doctors are looking at me like, are you mad? You would kill this woman if you gave her HRT. That's how serious people were. No one talked about it. And I feel quite sad for those women, really, because they really were just, it was taken away from them overnight. It just wasn't talked about. People thought it was too dangerous to be using. But over time, people have combed through that data. They've really gone back over it. And actually now we kind of recognize that it just never would be presented in that way again. There is a risk of breast cancer when it comes to combined forms of HRT, so estrogen and progesterone forms of HRT, so the ones you have to have if you have a womb or endometriosis. And there certainly is a risk, and that's fine. There are risks with lots of medicines and drugs that we give out. But what we need to do is we need to frame that risk in the context of the patient that sat in front of us. So we need to look at it in comparison to other things that are risky for breast cancer. So your biggest risk for breast cancer is age. The risk of breast cancer increases with increasing age, and particularly when we get above 50. So when I'm using combined HRT in women who are perimenopausal, their baseline risk of breast cancer is really low. And they would have a risk of breast cancer if I was prescribing the combined pill or the progesterone-only pill for contraception, but we don't hammer that home to them when we're having those discussions. And so it's all about looking at risk in the context of the patient. So it's about things like looking at family histories and actually examining whether that family history does mean that they've got an increased risk, because although patients might think that they've got this massive risk of breast cancer because there's someone in their family with breast cancer, it doesn't often constitute a risk to them. We need to look at their lifestyle. So things like smoking increases your risk of breast cancer by more than HRT. Drinking 2 units of alcohol a night will increase your risk of breast cancer more than HRT will. And being obese, so BMI over 30, hugely increases your risk of breast cancer. And even things like not doing regular exercise increases your risk of breast cancer. So I guess when I'm talking about it with women, I'm not saying that there isn't a risk when we're using combined HRT, but what I'm saying is let's put that risk in context for you and see how you then feel about that risk. Don't let it be a barrier for even having the conversation. And I think that's really, really important, because you could look at it, if you're going to look at risk, you've also got to look at benefit. And for many of these women, there are significant benefits to their lifestyle of going on HRT. So they might not have those 2 units of alcohol a night because, they can sleep better. So they don't need to have a glass of wine to get them off to sleep. Or they're not sort of drowning their feelings by having an extra glass of wine. They might have less joint pain and less hot sweats. And they might just feel mentally better. So actually they can go out and do some exercise. Oh, lo and behold, if they're exercising better, they might make healthier choices with diet and they might lose a bit of weight. So it's all about context, and it's all about, personally for me, I think that we downplay the role of lifestyle factors in the risk of breast cancer, but we're very, very happy to plaster headlines across newspapers that say HRT will give you breast cancer. But what we don't have is a big bus going around the country saying drinking 2 units of alcohol a night will increase your risk of breast cancer by more than HRT, because that doesn't suit the agenda.
And I love how you frame that, because it is so complex, isn't it? And I think that's what I really appreciated when I came to see you, because I was balancing my sanity and my safety. So I was like, I'd got to the point where actually this was impacting my quality of life, not having any HRT, even if there was a risk. I was like, how do I navigate this? And you kind of held me beautifully through that process. I have many people in my network that have had breast cancer. So if you have had somebody that has had breast cancer, what are their options? And again, I know this is very nuanced because there's different types of breast cancers, but where would you be pointing people to if they've actually had a breast cancer?
Yeah, and it is complicated and it is nuanced, but I think it's really important that just because something is complicated and nuanced, we don't shy away from talking about it. And so, Nikki, I have a particular passion about talking about breast cancer patients because I think they get a really bum deal. Because, there's all this conversation going on about, HRT and how wonderful it is and, everyone's taking it. And these are a group of patients that just don't feel heard, that don't feel that they've got a space at this table to have these conversations. So actually, I run a menopause and breast cancer service within the NHS, which I set up, and it's probably one of my like proudest achievements. I just love doing that clinic and spend a lot of time, trying to advocate for women with breast cancer, because when a lot of the treatments that we use in breast cancer, they affect menopausal type symptoms. So they don't always put you into menopause, because don't forget, the majority of women with diagnosed breast cancer are postmenopausal, but they can make those menopausal symptoms worse. And of course, there's lots of people who get diagnosed with breast cancer who are on HRT, and then they have to stop their HRT. So all of a sudden their symptoms come back, and then we give them a drug which makes them feel worse. There's younger women who might be perimenopausal, or premenopausal. We might switch off their ovaries as part of treatment. And there are also some who obviously then go into this sudden chemical menopause, and there is a huge difference between a menopause journey and a sudden menopause. The symptoms are very severe. And so I think we really need to look at how we can support these women. And the problem is that I think lots of breast cancer surgeons, oncologists don't know how to navigate that space. And I think it's a lot to ask of a GP as well. So what happens is these patients just get lost in the system and they don't really know who to ask for help. But there's loads of things. And I think that what worries me is that with the conversations that you hear at the moment, the big fancy headlines of, if you take HRT, you won't get dementia, that's the most common one at the moment, I think. And, if you don't take HRT, you're going to die of a heart attack, and you're going to get osteoporosis, and that's it, doomed forever. And, if you're sitting there and you've had a breast cancer diagnosis and you're trying to deal with that, and you're just reading these headlines, it's devastating. And women actually come to my clinic crying, not because they've got breast cancer, but because they're thinking, oh my God, I can't take HRT. I'm basically doomed to this life of, osteoporosis and heart disease. And that's where I think we need to be quite careful about how we're having these conversations about HRT, and that it isn't this golden elixir. It isn't for everybody. And there are certain groups of people that might not want to take HRT, don't need to take HRT, or who can't take HRT. And it's really important that they are able to explore the options that are available to them. And that's when, hands down to you, Nikki, we've always said, and I've always said to you, is that lifestyle is key. And when I saw you, you had this really good lifestyle, you'd done all that stuff first. But often when I'm seeing people, they haven't done all that stuff. So often that's a good place to start. Heart disease and things depend on lifestyle more than anything else. So, bone building exercise is important for preventing osteoporosis. So we need to try and get those things going. But sometimes it can be hard to do those things when your symptoms are bad. So we have to look at, what other options do we have for treating things like hot flushes and night sweats? There are drugs such as some of the antidepressants, which, no, we're not fobbing you off with an antidepressant. We're using the way that they work, the chemical ways in which they work can switch off hot flushes and night sweats. We've got things like bladder drugs. There's a bladder drug called oxybutynin, which we found out is quite good at treating hot flushes. So that's a useful one I'll sometimes use. We've got new drug Veoza, which has just been approved by NICE. Brilliant option, non-hormonal treatment for hot flushes and night sweats, and can help with sleep as well. So I think there are lots of medical options. There's also lots of other options. So there's the lifestyle stuff. If we can help women to support them to lose weight, they will have a reduction in their night sweats. They will have a reduction in their cardiovascular risk. Things like acupuncture can really be helpful. Some women find things like hypnosis really helpful, or cognitive behavioral therapy. So there's like a whole toolbox that women can explore, but they're only going to know about this if someone can sit down and have a conversation with them about it.
Brilliant. And would somebody that has had breast cancer, can they have, we've talked the difference between topical estrogen versus vaginal estrogen. Yeah. Could they have vaginal estrogen?
Yeah, so vaginal estrogen is different, and I think it's really good to clarify that. So when I generally talk about HRT, I'm talking about systemic forms of HRT, so your estrogen and your progesterone. And then there's the localized treatments, so your vaginal pessaries, your creams, and there's even a vaginal estrogen ring that you can use. And they are very different. So they are absorbed locally into the local bloodstream. They just go into the tissues where they are used and can be really, really helpful at supporting, vulval dryness, vaginal dryness, painful sex, urinary tract infections, bladder issues, so increased frequency. They can support women who have got prolapses. Really, really helpful. And we do use them in our breast cancer patients. So anyone who's had previous breast cancer, or patients who are on tamoxifen, they can use, and it is in the guidelines that they can use vaginal estrogen. Anyone who is on, there's another type of drug called a aromatase inhibitor, which is aiming to really flatline levels of estrogen. It's a little bit more complex, but still, we can have discussions with breast teams, we can have discussions with oncologists, and there are patients that I do use it in who are on those treatments. And there are other treatments as well that can be explored for those symptoms. So there are so many options for those type of treatments, and absolutely they're the type of treatments that actually may be available to people who cannot take the systemic HRT, and definitely worth exploring.
That's really useful to know. And the reason I keep bringing up about the vaginal estrogen, it just was not something that came across my awareness at all. And I was listening to a podcast actually that Davina McCall did with a sex therapist expert, and I can't remember her name. She's an Australian woman who back in like the 90s was always on like Cosmopolitan writing kind of the sex columns. And she shared that she'd had, and I don't know if I'm going to get the term right, is it vaginal
atrophy?
Atrophy, yes. When she said, even as a sex therapist, she said, I know as much as there is to know. She said, I'd never heard of this before. So can you explain what that is? Because that's what put it on my agenda. And I was like, wow.
So vaginal atrophy is basically what happens is as you lose estrogen, the tissues that are so reliant on estrogen in the vagina, the vulva, the bladder, the pelvic floor, they can become weaker, they can become drier, they can become thinner, they can become more fragile. Often women postmenopausally will notice that they get, now I need to be clear here, not a disappearing labia, because this is another thing that's going around TikTok and the internet is like disappearing labia. But the labia do become less plump. And so vulvas do look very different in the pre and post menopausal stage. I think some women can be quite shocked by that. You get less collagen in those tissues, but like you get less collagen everywhere as we age. And so, we need to look after those tissues. So it's kind of the old name used to be vaginal atrophy. I don't love that term because I think, when you say it, it just feels horrible. It feels like, God, is there not enough to be contending with? But now my vagina is withering away as well. Like it doesn't feel good. And so now we would tend to use GSM or genitourinary syndrome of the menopause, because that is a really good term to use because it's about the genitourinary symptoms. So it's not just vulvas and vaginas, it's the bladder and the urethra as well. But also it relates it to menopause. So it's about the loss of estrogen. So it's telling us why this is happening. And I quite like the idea that it's got the word syndrome in it as well, because it is a lifelong thing. So you can have women in their, 60s, 70s, 80s, 90s care home residents, who would really benefit from some vaginal estrogen still. And it's not too late, because that might prevent them from getting how many, I'm a GP, so I have spent my life going in and out of care homes. And so many of those women in and out, UTIs, back in hospital, urosepsis, really high mortality rate for women from something like urosepsis, which can come from a UTI. So, and then they get delirious with their urinary tract infection. Then they fall over, then they break their hip because their bones are fragile, because no one ever told them about the menopause and how important it was to do bone building exercise and all of that. So we've got this real problem. But we can use vaginal estrogen, and it's safe and it's easy. And we need to be using more of it, essentially, because you need to be using it long term. So when you're using your vaginal estrogens, which can come in the form of creams, pessaries, like I said, a ring, if you stop them, your symptoms will probably come back. And most women will experience some symptoms of, vaginal, bladder, vulval, sexual issues around menopause, but a minority of those women will come forward and talk to us about those. So we need to be proactive in talking to our friends about them, in like breaking down this shame and stigma. And, you have to name it to unshame it. Someone once said to me, and I thought that's brilliant. Yeah, the more we shout about this, the more we talk about it, the more I wang on about vaginas and things like that, people might start to kind of switch on and listen and notice the bigger picture. So yeah,
and I would really encourage people listening to, as you say, have these conversations, because it was only in a conversation with actually an old school friend, and I was saying, I was listening to this podcast and was having a conversation about it, and she'd gone into early menopause. Actually, she was in her 30s, and she shared that she had had this experience and was in, horrific pain, and it was, really impacting her life quality. And I was like, oh my God, there's somebody that I didn't know in my network that was actually experiencing it. And that's when I'd said to you when we were in consultation, I was like, right, talk me through this. What's
going on here? Yeah.
What do I need to know?
Really impact on people's lives, and it impacts on their sex lives. And that's really important to women. And like you said, it's particularly that, to go into your menopause in your 30s, it's really young. And that does have significant health consequences. So we really need to look after that woman for the rest of her life. And we need to be thinking about all the things that might be depleted of estrogen, and that includes those tissues as well. So,
yeah, and it made me think, you mentioned earlier about eyes. I had this situation about 6 months ago where I woke up and I thought that I'd got a eyelash in my eye. And by about an hour later, I was like, this is really distressing. And I ended up having to book an emergency appointment at the optician's. And I was like, I'm so embarrassed. It's just an eyelash. And when she looked, I'd got a severe abrasion across my eye. And I was like, what would have caused that? And she was like, well, can be perimenopause. I was like,
the gift that keeps on giving.
Yeah. And I'd got this severe abrasion because, again, I hadn't realised that the estrogen affects the kind of lubrication around your eyes.
So many women have dry eyes, and really easy to treat as well, with lubricating eye drops. But also maybe if it's suitable for you, some general estrogen being back in your system can be really helpful for those symptoms as well. I've seen people with, my husband's a dentist, and he sees lots of people with like dry mouth or burning mouth syndrome as well. It's very, very common during the perimenopause, menopause. And I've seen some cases of like burning mouth that have been so severe. I had one patient, this woman, she could only drink like liquid things, and she lost so much weight. And actually for her, just replacing some estrogen, just a teeny tiny smidge, really, it didn't solve her symptoms, but it made them much better. And she was able to eat again and put on some weight because she'd become quite severely malnourished. So it's things sometimes that you don't even think of that are worth mentioning, because they may be to do with it. There's lots of other reasons why you can get those things as well. So that's what I was saying before about how important it is to make sure that, if things aren't getting better, let's switch our head back on and think again. Or do we need to rule out other things like fibroids or whatever, or thyroid issues or things like that before we go down this route?
I just feel very grateful to have had your support on my journey, and the fact that you proactively got me onto HRT just before my operation, a couple of weeks before, to get it in my system. And it has genuinely been life-changing for me. So thank you. If there was just one thing that you would want somebody who's listened to this conversation to take away, what would you want that to be?
I think it would be, don't be frightened about perimenopause and menopause. I think sometimes we see it as a very negative stage, whereas I think it's a great time to I always say to women, put your ducks in a row for health, because I think it's a really pivotal point in, women's general lives, but it's a really pivotal point in your health as well. And we want to be living in a body for the next few decades of our lives that is healthy and as disease-free as possible. So it's a really good moment in time just to kind of gather your thoughts about the way you're living your life and any changes that you can make, but also your overall health. And don't think that it's all doom and gloom. Plenty of women in perimenopause, the Japanese call it second spring, and it can be quite an empowering time. But sometimes that gets missed a bit in the kind of being bogged down by all the symptoms. So if you're struggling, then speak to someone. Have the conversation, open your mind a little bit to what's out there, and try and look for information in sort of evidence-based sources. There's an awful lot of myths and misconceptions flying around the internet at this particular time, which worries me every night when I go to bed. But, I think don't let that put you off. Things that you've heard, go and check it out with a reliable source, and actually just sit down with someone and have the conversation and just be honest about how you're feeling and how these symptoms are making you feel, because it might be HRT, but there are lots of other things that we can do to try and support you with these symptoms, and you don't have to kind of go and suffer it alone.
Brilliant. Well, thank you for being the reliable source in my life. And I'm sure people are going to want to find out more about you and some of the kind of information you share. So where would you point them to? So
I work at Menopause Care Limited, so people can get in touch with me there. There's quite a lot of information on our website. And I am on Instagram. I'm very, very bad at keeping up with Instagram. It's Dr. Charlotte Gooding. But I tend to not share too much medical information because I would probably never go to sleep. And just have with that and 3 children and a small football team to manage, a girls' football team, I just don't think I'd have any time to do Instagram content. But yeah, you can find me there if you need me.
But I love following you on Instagram because you show the realities of you navigating your life as a perimenopausal woman. You've got 3 kids, you're a busy GP, you've got a dog as well as the football team.
Puppy.
And I just love, because you keep it real, and it's like, well, this is my moment of self-care and how I'm finding it in.
I just think there's too much. There's so many smoke screens, isn't there? I think it's really, I'm a health professional, but it's very easy for me to get sucked down a rabbit hole at midnight when I'm scrolling on my phone, and all of a sudden I'm like, oh my God, I should take that supplement. My life isn't as good as this. I'm not as good a doctor as them, and I'm not helping as many people, and it's really easy for us all to do that. So I just think there is a little bit of something nice about sharing the reality of situations. When you forget to put the rice in the rice pudding because your perimenopause brain fog's stopped you from reading a recipe properly. That is the reality of life. And sometimes it's nice to share those things as well as the glossy.
And finally, you mentioned earlier that you do the NHS breast clinic.
Yeah.
Where would you point people to if they wanted to find out more about that?
Yeah, so that's in Newcastle. So I'm only allowed to see patients in Newcastle. But if you happen to be a patient in the surrounding area, then oncologists will often get in touch with me and ask for advice. If you're lucky, there are a few other areas, Glasgow, Cambridge, where we do have menopause specialists within breast teams. And I would like to see a day where every single breast team has a menopause specialist sitting alongside them. And I hope that day will come. But, there are a few of us floating about. And I think education is improving within breast care. I talk at breast conferences, so do some of my colleagues that do this type of work. So we are trying to get the information out there, and I think it is getting better. But one really, really great source of information for breast cancer patients is the Menopause and Cancer website. And Danny Bennington has done an incredible job there. And she also has a really good podcast, which I would really encourage any cancer patients who are struggling with menopause to go through. And that's where I would usually signpost patients to for evidence-based, accurate information, and just a shared understanding, which I think is completely invaluable in these circumstances.
Brilliant. Thank you, Charlotte, for joining me today, but also for the work that you're putting out into the world, because I know I've benefited greatly from it, and I hope people listening will do too.
Well, thank you, Nikki.
If you've enjoyed this episode of Wisdom for Working Mums, I'd love for you to share it on social media or with the amazing women in your life. I'd also love to connect with you, so head over to luminate-group.co.uk where you'll find ways to stay in touch. And if this episode resonated with you, one of the best ways to support the show is by subscribing and leaving a review on iTunes. Your review helps other women discover this resource, so together we can lift each other up as we rise. So thanks for listening. Until next time, take care.